Thank you, sir. Thank you, sir. So next session is management of cerebral edema in acute ischemic stroke. I would invite Dr. for the chairing the session, Dr. Anjani Sharma sir, Dr. S.P. Patidar sir. I would request Dr. Yashpal Singh Rathod sir to present the bouquet to the chairperson. Dr. Anjani Sharma sir is the director of the neurology at C.K. Birla Hospital, Jaipur. And Dr. S.P. Patidar sir, he is a HOD and the senior consultant of neurology at Jeevan Rekha Hospital, Jaipur.
Good evening. Now we move on to the second talk of this session on acute this management of cerebral edema in acute ischemic stroke. For that, I request Dr. Venkatesh to deliver this talk. This is a very common clinical problem which we come across in the management of acute ischemic stroke. May I request Dr. Venkatesh?
Yeah, before Dr. Venkatesh starts his talk, I would like to introduce Professor Venkatesh. Dr. Venkatesh, first of all, very good morning to you. And it's a real, indeed, a great pleasure and honor for us that you could spare time to deliver talk on management of cerebral edema in stroke. Professor Venkatesh, he was the best outgoing student at Calcutta Medical College, Calcutta. Then subsequently joined DM Neurology at Nimhans, Bangalore, and there too he was a best outgoing DM resident. He got gold medal. Then after that, he moved to New York for residency in neurology. And after residency in neurology, he did fellowship in neurocritical care and worked at St. Louis, USA. Then subsequently after that, at Chicago, and presently he is a professor of neurology and director neurocritical care at UT Southwestern Medical Center, Dallas, Texas. With these few words, I welcome you, Venkatesh, to deliver your talk on cerebral edema in stroke. Thank you, Dr. Venkatesh.
Thank you, Suresh. Can you hear me and see my slides?
Yes, you can.
Good evening. It's a real pleasure to be able to give this talk. I know Suresh for almost 35 years, and we've had a very strong association, and he's one of my best friends, as well as one of my first teachers in neurology. And so I'm very happy to give this talk on cerebral edema and ischemic stroke. So the topics we're going to cover today is, first, I'm going to talk about the pathophysiology of cerebral edema and ischemic stroke. Then we're going to discuss the consequences and predictors of cerebral edema. And then lastly, we're going to cover the management of cerebral edema in ischemic stroke, both medical and surgical. And at the outset, I would like to state that this talk is going to be confined to large hemispheric ischemic strokes. I will not be discussing, for example, the management of cerebellar infarction, which is a whole different topic of its own. So cerebral edema, as all of you know, is defined as abnormal accumulation of fluid within the brain parenchyma, which leads to an increase in brain volume. We now currently classifies cerebral edema as either intracellular edema, which is otherwise known as cytotoxic or just cellular edema, and extracellular edema. Extracellular edema is further subdivided into ionic edema, where the fluid is poor in protein, vasogenic edema, where the edema fluid is protein rich, and lastly, hemorrhagic conversion of infarctions, for example, where the edema fluid is bloody. Especially for the purposes of stroke, it is helpful to think of cerebral edema in stroke as a continuum and not think of it in isolations. And this edema has components of both intracellular and extracellular edema, starting first with intracellular cytotoxic edema and then progressing to extracellular edema, where the edema fluid is at first poor in serum proteins and then later on becomes a protein-rich fluid, and finally the edema fluid gets reabsorbed. So this slide essentially illustrates some of the current understanding of the mechanisms of cerebral edema in stroke. So in the middle here is a pictorial representation of an astrocyte, which is surrounded by sodium ions in green. Next to that is a blood vessel, and the blood vessel also contains sodium ions in green, albumin molecules in orange, and red blood cells in red. Whenever there is a disruption in cerebral blood flow, as in stroke, the first thing to happen is a depletion of ATP and mitochondrial dysfunction, which leads to a loss of the sodium-potassium ATPase pump and an inability to keep sodium ions out of the cell. In addition, there is increased expression of 3 receptors, and these are the aquaporin 4 receptor, the sodium potassium chloride cotransporter, and the sulfonylurea 1 regulated receptor. And as a result of increased expression of these 3 receptors, this allows channels to open up in the cell wall and facilitates the entry of both water and sodium into the cell, leading to cytotoxic edema. So once this has happened, the extracellular fluid is now depleted of water and sodium ions because they have entered the cell. And this leads to a gradient which facilitates movement of water and sodium from the intravascular compartment into the interstitial compartment. And these receptors, the aquaporin 4 and the sodium potassium chloride cotransporter channels, can also have increased expression in the vascular bed as well. On the other hand, if there is further injury to the vessel wall itself, there can be breakdown of these tight junctions between the endothelial cells, and this leads to extravasation of fluid, serum proteins, as well as in extreme cases, extravasations of RBCs, leading to vasogenic edema and hemorrhagic conversion. And it's important to remember that actually it is more of the astrocytes that are the major player in cytotoxic edema, and cytotoxic edema here is actually the driving force for ionic edema. Why are we talking about these receptors, and why is it important to understand this kind of molecular neurochemistry, if you would say? And the reason is that some of these receptors are now being explored as treatment targets to treat cerebral edema. So for example, IV glyburide actually blocks the sulfonylurea receptor and has been shown to attenuate cytotoxic edema. Bumetanide, a loop diuretic, blocks the sodium potassium chloride cotransporter channel. And on the vasogenic side, endothelin receptor antagonists, inhibitors of matrix metalloproteinases, as well as dexamethasone have all been tried to stabilize this endothelium tight junctions and thereby treat vasogenic edema. Lastly, it has also been postulated that the edema fluid in stroke is derived from the CSF rather than the blood vessels themselves. And a more elaborate discussion on this topic is beyond the scope of this talk, and the therapeutic implications of this are still unclear, but this is a topic of increasing research. This slide actually illustrates the time course of cerebral edema. If you look at this graph on my extreme left, this shows that autopsy studies reveal a significant increase in the weight of the ipsilateral cerebral hemisphere that happens in the first 5 days after an ischemic stroke. Similarly, if you look at the evolution of midline shift on a CT scan, it seems to peak around day 5 in survivors. However, in patients with very large infarcts and those who die from cerebral edema from stroke, this cerebral edema can occur much earlier, and you can see a peak of cerebral swelling as early as 24 to 48 hours itself. And lastly, this slide here shows the evolution of intracranial pressure increases in stroke. And again, in survivors, it seems to peak at about day 3 to 4, and in non-survivors, it continues to increase until death. Now, moving on to cerebral edema in large hemispheric infarctions, this is kind of a pictorial representation of what we're going to talk about. This is a patient of ours who had a acute left MCA occlusion and went on to develop, as you can see, a complete NCA infarct with significant midline shift, obstruction of the foramina Monro, and development of contralateral hydrocephalus. The first question that would come to mind is, why do we really care about learning about cerebral edema and stroke? And the reason is that if you look at the causes of death in stroke, among those patients who have early neurological deterioration, cerebral edema accounts for nearly half of all the causes of death in these patients. And even in those patients that do not have early neurological deterioration, 1 in 7 of all deaths is again due to cerebral edema. So cerebral edema is a very important contributor towards mortality in patients with ischemic stroke. And because this is the case, it is probably helpful for us to try to see if we can predict which of these patients are at significant risk for cerebral edema. And this slide is by no means a completely exhaustive slide. But just to emphasize some of the important predictors of cerebral edema in stroke, among the clinical predictors, the presence of headache, nausea, and vomiting, a declining level of consciousness, dilatation of the pupil, and a high NIH stroke scale or a low GCS score are all clinical predictors that the patient is going to develop significant cerebral edema. If one looks now at the radiological predictors on a CT scan, an early hypodensity involving more than 50% of the MCA territory, the presence of a dense MCA sign, the presence of a pineal shift of more than 5 millimeters within the first 48 hours, and an aspect score of less than or equal to 7 are all radiological predictors of significant cerebral edema. There are also predictors on MRI, namely a DWI infarct volume of more than about 80 ml in the first 6 hours or more than 145 ml in the first 14 hours. And on a CT angiogram or a cerebral catheter angiogram, the presence of a combined MCA and an ACA occlusion. So once a patient has developed a large cerebral hemispheric infarction, this infarction and the consequent edema leads to several pathophysiological consequences, and it affects intracranial dynamics in several ways. So first of all, the swollen brain, through the local mass effect, will compromise the functioning of adjacent non-ischemic neurons, which leads to worsening of the neurological deficit. And as this progresses, one can start to develop herniation syndromes. And by that, I mean displacement of the brain structures from their normal location. And though classically we think of herniation syndromes as downward displacement of the brain, for example, a downward displacement of the uncus, we have now come to realize that it's actually the lateral displacement of the midbrain to the opposite side, which is probably a more important cause of the decrease in level of sensorium and even the development of pupillary abnormalities in these patients. If there is further lateral displacement, again, this can lead to compression of the foramen Monro and development of obstructive hydrocephalus, and the increased cerebral edema plus the obstructive hydrocephalus together will increase intracranial pressure, which will further decrease cerebral perfusion and lead to decrease in cerebral blood flow, worsening ischemia, and this can set up a vicious cycle. Now, one of the other questions that comes up is there any value in measuring or monitoring intracranial pressure in these patients? And if ICP is a contributor, should we be checking ICP in these patients routinely? The current evidence suggests that this is probably not helpful. I have listed here 3 early studies of ICP monitoring in patients with deteriorating large hemispheric stroke. And as you will see in all 3 studies, the ICP initially in these patients was within normal limits, even when the patients were deteriorating clinically. And the reason for this is, as I mentioned, that the clinical deterioration in these patients early on is more due to lateral displacement of the midbrain and the other brainstem structures rather than increased ICP. And if you place an ICP monitor, it really does not work as an early warning sign of worsening intracranial dynamics. And at worst, it might give the clinician a false reassurance that everything is going okay, even while the midline shift is continuing to get worse and the patient is deteriorating. The one benefit of the ICP monitor, if you want to call it, is that it does serve as an important prognostic marker in that if ICP is elevated in the setting of an ischemic stroke without effective treatment, this is associated with a high mortality. Next, we'll move on to the treatment of cerebral edema. And here I'm going to largely cover mainly 4 topics. First, we're going to discuss hyperosmolar therapy or osmotic therapy. Next, we're going to talk about decompressive craniectomy. Then we're going to move on to discuss hypothermia. And lastly, we're going to talk about some new therapies that are being explored in the management of cerebral edema. So first, moving on to hyperosmolar agents like mannitol or hypertonic saline. So as you know, the way these osmotic agents work is that these agents increase intravascular osmolarity. And this leads to a shift of fluid from the interstitial compartment to the intravascular compartment, and thus decreasing brain volume and thereby decreasing intracranial pressure. Now, underlying all this is the assumption that the blood-brain barrier should be intact in order for this to happen. The commonly used osmotic agents, at least in the United States, are mannitol, which is available in concentrations of 15 to 25%, hypertonic saline, which is available in concentrations of 3% all the way to 23.4%. Nowadays, we're also using buffered 3% hypertonic saline with sodium acetate instead of purely sodium chloride to try to obviate the hyperchloremia, which some of these patients have that has been associated with renal failure. Glycerol is used in Asia and some European countries, but it's not used in the US for treatment of cerebral edema. And below that, I have listed some of the equivalent osmolarities of these substances. So 20% mannitol is more or less equiosmolar to 3% sodium chloride, and they both have osmolarities of around 1,000 milliosmoles per liter. Now, what is the rationale for using osmotic therapy in ischemic stroke in the first place? And this has been an area of controversy, and there are both cons and pros for the utilization of this treatment. People who argue against the use of osmotic therapy would say that global ICP elevation, as I discussed before, is really not a major cause of early worsening in ischemic stroke. So why are we trying to use an agent that primarily works to lower ICP? We also know that for osmotic agents to actually work, the blood-brain barrier has to be intact. So mannitol and hypertonic saline will predominantly shrink the unaffected hemisphere. They will not actually work to reduce the volume of the infarcted cerebral hemisphere. Some people have also postulated that where the blood-brain barrier is broken, there may be a theoretical risk that these agents might be accumulating in the infarcted tissue and might theoretically worsen the infarct volume. And lastly, the available studies do not support a mortality or outcome benefit with the routine use of osmotic therapy in ischemic stroke. On the other hand, all of us have seen evidence of reversal of signs of herniation. For example, a dilated pupil becomes constricted again with a dose of mannitol, as well as improvement in the Glasgow Coma score with osmotic therapy. There is anecdotal evidence and case series of patients with large ischemic stroke that have improved with osmotic therapy, and I'm going to give you some examples of that in the two subsequent slides. And lastly, mannitol has been postulated to improve blood viscosity and potentially improve blood flow to the brainstem that has been displaced by the infarcted hemisphere. And this might be another mechanism by which these agents work. So this paper is an example of the use of osmotic therapy in patients with large hemispheric stroke. So this study looked at 30 patients with large hemispheric infarcts with a median NIH stroke scale of 19. And they showed that about 47% of these patients survived with just osmotic therapy alone. And as you can see in this graph, the lower the NIH stroke scale score, the better the chance of medical management. But even as you can see, there are some patients with an NIH stroke scale of around 30, and some of them survived just with osmotic therapy alone. And some of the factors associated with success in this study were black race, the presence of a lower NIH stroke scale score, not requiring osmotic therapy in the first day, and patients that required a lower dose of hypertonic saline. This is an example of one of my patients with a large MCA infarct. You can see that 60 hours after the onset, this patient has a midline shift of the septum pellucidum of almost 10 millimeters. This patient's family did not want hemicraniectomy, and this patient was treated with osmotic therapy. And you can see that 3 weeks later, the midline shift has almost completely resolved, and this patient actually recovered and went home. So there are definitely some of these instances where osmotic therapy works. The challenge is trying to figure out in which patient osmotic therapy alone will work and which patient will need something else. So I thought I'd also cover some of the general principles of the use of osmotic therapy. So first of all, I would like to emphasize that there is no role for prophylactic use of osmotic therapy in every patient with ischemic stroke. I use it only for patients who show some evidence of clinical deterioration with radiological worsening in the form of increasing midline shift or worsening sulcal effacement. We do not routinely use it in every single patient with stroke, even in those that have a slight degree of midline shift but are clinically stable. Second, whenever you use any form of osmotic therapy for more than 48 hours or so, the treatment should always be tapered before stopping, and do not stop osmotic therapy abruptly, because this will lead to a risk of rebound cerebral edema. Third, do not use hypotonic maintenance IV fluids in these patients. Don't use half normal saline. Don't use 5% dextrose water, as it defeats the purpose. You're trying to make the blood more concentrated, and using dilute solutions is actually going to work against you. Fourth, whenever you use osmotic agents, and especially mannitol, which is a powerful osmotic diuretic, always keep an eye on their intake and output and maintain euvolemia. The goal is to keep the patient hyperosmolar and not to make the patients hypovolemic. Hypovolemia will lead to potentially a drop in blood pressure and a further drop in cerebral blood flow, which we want to avoid. And then lastly, be aware that because of a generation of idiogenic osmoles by the brain, when you use osmotic therapy for a prolonged period of time, as time goes on, you may need to use progressively higher doses of the substance in order to maintain the same effect, because the brain increases osmolarity and the previous doses of mannitol will no longer be effective. When we use mannitol, if the patient has evidence of acute herniation, usually large doses are administered. We would give a rapid IV infusion of 1 to 1.5 grams per kilo. The commonly used maintenance doses are in the range of 25 to 50 grams every 4 to 6 hours. Generally, in the setting of large hemispheric infarcts, we would use it for about 5 or 7 days, followed by a taper over in the next 2 to 4 days. You need to watch for some of the side effects of mannitol, and these might include electrolyte disturbances like hypo and hyperkalemia, hypomagnesemia, and hypophosphatemia are again quite common. Very rarely, you can also see hemolytic anemia from mannitol. Use it very carefully in patients with heart failure, because acutely mannitol is going to act like a volume expander and can potentiate acute heart failure. And also avoid using mannitol in patients with renal insufficiency, as it is renally excreted. And if you don't monitor it carefully, then you will have progressive accumulation of mannitol in the blood. And we have actually had 1 or 2 patients who developed hyperosmolar coma, not from the stroke itself, but from the inappropriate use of mannitol. Many textbooks actually recommend monitoring osmolarity when using mannitol, and they say that you should keep the osmolarity between 310 to 320 milliosmoles per liter. There's really no strong evidence to support this practice, and if needed, mannitol can be used with targeting much higher serum osmolarities than these numbers that I have quoted, provided that you make sure that all the mannitol that you've given has been completely excreted before you give the next dose of mannitol. And the way we do this is by monitoring the osmolar gap just before each dose of mannitol. And because mannitol is an unmeasured osmol, this osmolar gap acts as a surrogate for the mannitol level. So the osmolar gap, as you remember from your internal medicine days, is calculated by sending a measured osmolarity to the lab and then calculating the osmolarity from your sodium, BUN, and glucose. And the measured osmolarity minus the calculated osmolarity will give you your osmolar gap. And generally speaking, an osmolar gap of less than 20 would indicate that all the mannitol that you have given earlier has been completely cleared, and it's okay for the patient to get a next dose of mannitol. And if the osmolar gap is higher than 20, we should probably delay the dose by an hour or 2, and the next dose should probably be smaller than the one that you've given before. Recently, we are using more and more of hypertonic saline rather than mannitol. And when we use 23.4% saline, 0.7 ml of 23.4% saline is equiosmolar to a gram of mannitol. So if you want to give about 50 grams of mannitol, you can convert that and it works out to about 35 ml of 23.4% saline. So the commonly used doses are 30 to 50 ml of 23.4% saline. If you don't have this concentration available, if you have only 3% available, the commonly used dose is about 250 ml of 3%. So some of the advantages of hypertonic saline over mannitol are that one is it can be used in renal insufficiency. It is useful when when a volume expansion is desired, for example, in patients with traumatic brain injury who also have other organ injuries. It has probably a little bit of a less of a diuretic effect than mannitol. And monitoring hypertonic saline is definitely easier than mannitol. You don't have to worry about osmolar gap. One of the main disadvantages, especially if you're using 23.4% saline, ideally you would like to have a central line placed. Some physicians use continuous infusions of hypertonic saline rather than giving bolus doses. I believe that continuous infusion is not really supported by our understanding of how we think osmotic agents work, and that continuous infusions may actually promote synthesis of idiogenic osmoles and may favor the movement of solutes into the brain. So generally, we do not use continuous infusions of hypertonic saline unless we are treating hyponatremia, which is a completely different subject. And when we use hypertonic saline, we try to keep the serum sodium less than 160 milliequivalents per liter. If you go above that, then this becomes an independent predictor of mortality. And as far as the clinical relevance between the choice of hypertonic saline to mannitol, in some studies, the use of hypertonic saline has been associated with a lower ICP of about 1 to 2 millimeters of mercury. Whether this is of practical relevance or not is really unclear. We usually look at other factors such as how easy it is to give, whether the patient has central venous access or not, whether the patient has renal insufficiency or not, to decide whether we're going to choose hypertonic saline or mannitol. Now let's move on to surgical treatment, which is decompressive craniectomy for these patients with large hemispheric stroke. And before that, it's helpful to just review the modified Rankin scale because it'll help us understand some of the questions that come up when offering these patients hemicraniectomy. So modified Rankin scale of 3 means that the patient has a moderate degree of disability and requires some help, but is able to walk unassisted. Whereas a modified Rankin score of 4 means the patient is unable to walk, unable to attend to their own bodily needs without assistance. So these are the 2 that are going to be important when we talk about in the subsequent slides. So recently, there have been several studies looking at the effect of decompressive hemicraniectomy in these patients. And physiologically, it would make sense that if you take off the skull on the side of the infarct, the edematous brain would bulge out of the craniectomy site and not press on the normal hemisphere. And there have been several trials that I've listed here. Essentially, most of them enrolled patients between the age of 18 to 60, except for Destiny 2, which enrolled patients greater than the age of 60. The time of onset of decompressive hemicraniectomy in these trials varies to between as early as within 24 hours to as late as within 96 hours. Various NIH stroke scale criteria, various imaging criteria, either more than 50% or 2/3 of the MCA territory had to be involved, or in those that used MRI, a DWI volume of more than 145 ml, and an outcome of either modified Rankin score of 0 to 3 or 0 to 4 at 6 months was considered to be a good outcome. And if you sum the results of most of the major trials, what you will see is that this is actually the distribution of the modified Rankin scales at 6 months. So early decompressive craniectomy, which is craniectomy done within 48 hours, as opposed to pure medical treatment, decreases mortality by 50%. So it'll drop your mortality from 75% all the way down to 30%. But what is important is to note the very important influence of age on this outcome. And this is a number that I like to remember and quote when I discuss statistics with my patients, that if you have a patient who's less than 60 years old, for every 10 surgeries that we do, we will save 5 lives. And out of those 5 lives saved, one patient will end up with a modified Rankin score of 2, which is a very good outcome. One patient will end up with a modified Rankin score of 3, which is not bad. And 3 patients will end up with a modified Rankin score of 4, which is not that great. However, in patients above the age of 60, for every 10 surgeries, you will save only 3 lives. And out of those 3 lives, 2 will end up with a modified Rankin score of 4, and 1 with a modified Rankin of 5. And this flowchart explains how we approach this when we talk to patients. So we ask ourselves in the family 2 questions. 1, what is the patient's age? And 2, what is the quality of life that would be acceptable as a good outcome to the patient and the family? So let's take the best case scenario, which is the patient who's less than 60 years of age, and the patient's family says that an MRS score of as high as 4 is acceptable to them. So in this patient, hemicraniectomy has almost 70% chance of giving them a good outcome. On the other hand, if you look at the worst case scenario where you have a patient more than the age of 60 and the family says that for them, the only acceptable good outcome would be an MRS score of 0 to 3, for that patient, you have a less than 10% chance of offering them that scenario. So this kind of helps paint a picture both for us and for a family to decide whether the patient should or should not be taken for decompressive hemicraniectomy. Now, moving on to hypothermia, this is something that showed early promise, but recently there have been several trials of hypothermia and stroke that show that hypothermia can be achieved and maintained, but there seems to be a high risk of pneumonia with these patients. And also, addition of hypothermia to hemicraniectomy does not improve mortality and has a significantly high and probably unacceptable adverse event rate. So this is kind of falling out of favor. Lastly, to talk about a new therapy that's on the horizon for cerebral edema. As I mentioned earlier, glyburide given IV antagonizes the sulfonylurea 1 receptor, which is thought to be very important in mediating cerebral edema. So the GAMES-RP was a randomized, double-blind, multi-center phase trial, which enrolled patients with large hemispheric infarcts. This trial was concluded prematurely because funding was pulled by the drug company that sponsored the trial, and the trial did not meet its primary outcome measure, but there seems to be a signal towards improved survival in these patients that got the IV glyburide, as well as an improved midline shift in these patients that got IV glyburide compared to placebo. So this is a treatment that is potentially promising, and ongoing studies are being continued both in stroke and in traumatic brain injury. Lastly, just to go over the acute stroke guidelines. So these are the American Heart Association and American Stroke Association guidelines. So they recommend that use of osmotic therapy for these patients is reasonable. They do not recommend the use of hyperventilation, hypothermia, barbiturates, or steroids that I did not talk about. They say that it's reasonable to use decompressive craniectomy in patients that have a decreased level of consciousness. It is slightly has a stronger evidence in patients less than 60 years of age, not so great in patients more than 60 years of age. The European guidelines are also similar. strong strength of recommendation with moderate quality of evidence for hemicraniectomy in patients aged 60 years or younger. Again, not that great in patients older than 60 years. And similarly, they do not recommend the use of corticosteroids or hyperventilation. And the expert consensus statements states that we should not routinely use osmotic therapy, but we may consider it as a short-term, as a rescue procedure in cases of increased ICP or impending herniation. And they also suggest the use of bolus administration rather than continuous infusion. So lastly, just as take-home points, the pathophysiology of cerebral edema is still evolving. Cerebral edema remains a major cause of mortality in stroke. The peak period is around 3 to 5 days earlier in young patients and with larger strokes. Hemicraniectomy is a life-saving intervention, but the impact on functional outcome needs to be discussed with families in great detail, especially in patients who are more than 60 years of age, in order not to substitute mortality with severe unacceptable morbidity. There is a limited role for osmotic therapy in these patients, and IV glyburide is one of the treatments that is being currently studied. I'll thank you for your attention, and I'm happy to take any questions that you might have.
Thank you, Dr. Venkatesh. Summarizing this lengthy topic from pathophysiology to treatment and your aspect. Cerebral edema is common monster for all of us after 2 to 3 days, and our patients are fighting with cerebral edema. So you summarize it very well. Thank you, Dr. Venkatesh. Thank you for it.
Comments or questions from audience?
Sir, good morning. Just I wanted to know, in your practice, supposing a young patient is there with MCA infarct, you wait for him to deteriorate within 48 hours or prophylactically you plan for decompressive surgery? Thank you.
So that's a very good question. So if you look at the hemicraniectomy trials, they did not wait for clinical deterioration in these patients. So first is we would look at the infarct volume, and the data would suggest that if your infarct volume on a diffusion weighted MRI image, if that volume is less than 140 ml, then that patient will not need hemicraniectomy and that patient will do fine. If the hemicraniectomy volume is greater than 200 ml, if you do not do hemicraniectomy, that patient will die. So there's really no point in waiting. In between the area of 145 to 200 ml, again, the trials would show that hemicraniectomy has significant survival benefit, and at least some of them will have a good modified Rankin score. So for a young patient with an infarct that is between 145 and 200 ml, if the patient is sleepy, we would take the patient for hemicraniectomy. We would not wait for him to have a pupillary dilatation before we take the patient to the OR.
So what is the reason why the glyburide study was withdrawn, and why the funding agency stopped the drug, and who was the funder?
Sorry, I couldn't hear you properly. I know you're trying to ask a question on glyburide. I didn't understand the rest of it.
Essentially, what was the reason the study was prematurely withdrawn, and why the funding agency withdrew the study when the initial result was favoring the primary outcome?
I cannot answer on the basis of the pharmaceutical company. I am not, I do not know what their finances were. I don't know why they said that they ran out of funding. But again, it did not meet its primary outcome measure. So there was not a statistically significant outcome benefit that they had originally powered their study for. So maybe the drug company just wanted to have enough data so that the further larger trial would not have to be sponsored by them, but would be sponsored by the NIH. Drug trials in the United States are very, very, very expensive.
Any other question?
I think there are no more questions, and thank you, Venkatesh. Thank you. I think
Hello. Good evening, sir. I just wanted to ask about hyperosmolar therapy. Is there any added advantage of adding both together? Like if the patient is already on mannitol and you don't find in early 24-48 hours patient to be improving, and adding 3% saline over it. And if you are using only 3% saline, the guide to continue or to discontinue, would that be sodium, or in that case also you go according to the osmolarity?
So there are two separate questions. I'll take the second one first. So if you are using hypertonic saline, your calculated osmolarity will be very close to your measured osmolarity because there are no unmeasured osmoles in the blood. So you can monitor the amount of osmotic therapy that you're giving to that patient just by looking at their serum sodium concentration alone. You don't need to separately check for osmolarity. Unlike mannitol, where it is the mannitol itself that is increasing your osmolarity, and you have no way routinely to check mannitol levels. And the first question was, is there a benefit in adding the two? So we usually will add the two. For example, you gave somebody, started off with mannitol. You gave him, let's pretend that you have an ICP monitor, and this is not a patient with a stroke, but a patient with a head injury. So you gave him 75 grams of mannitol because the ICP was 30, and the ICP came down, but then 2 hours later, the ICP went up again. And at that time, the osmolar gap is still 40, so there's still mannitol in the system, but the patient's ICP is high, and so you don't want to give another dose of mannitol because then that'll just lead to accumulation of mannitol. So in that patient, instead of giving mannitol at 2 hours, we would give hypertonic saline. So we would use hypertonic saline in between doses of mannitol to allow the mannitol to be excreted, but at the same time provide some extra hyperosmolarity to treat the patient. As far as whether there is clinical benefit to the strategy or not, again, there are no studies that look at combined use of mannitol plus hypertonic saline and compare them to either mannitol alone or hypertonic saline alone. So we would only use it in situations where you think that one drug alone is not effective, mainly for toxicity reasons rather than clinical efficacy reasons.
So for using hypertonic saline alone, the sodium target, what you keep is that's 155 or 160?
So anything above 160 is been associated with increased mortality. So we generally target our sodium between 150 to 155 because, again, it is not very easy to titrate to a very exact sodium level. So if I want my sodium to be 159, I cannot always achieve 159 if I want to get it as high as possible, but not cross the 160 threshold. So generally, if we are already reaching the 155 range, we will probably try to back down on that.
Thank you, sir.
Hi, Dr. Venkatesh. Good evening. Since you are a neurosurgeon also, I would focus my question on the neurosurgical aspect. As you said, that early surgery within 24 to 48 hours, and you divided the age less than 60 and above 60. Above 60, you said if MRS3, the chances of improvement in 8% of the cases of 3 MRS. Now, early surgery means what do you mean by early surgery? In what cases early surgery within 24 to 48 hours to have good results? Because this will be your decision of surgery would be based on many factors: level of consciousness, deteriorating level of consciousness, ICT, CT scan showing shift. So is it that with all these standardized criteria of surgery remaining same, and then early surgery or late surgery? So what is the takeaway as an indication for early surgery?
So first of all, I'm not a neurosurgeon, even though I'm a neurologist and a neurointensivist, even though my faculty appointment is with neurosurgery. So there, in general, patients who need surgery would probably benefit from that surgery if done early, as opposed to if done late. The downside of that is doing early surgery means that you may be taking some patients to the operating room that might do okay even without surgery. So we look at a lot of different factors, and as I said, in my slide, so there are some clinical predictors as well as radiological predictors that would tell us that this patient has a very high likelihood of developing large cerebral edema. And these include things like young age, very large NIH stroke scale, decreased level of consciousness, a complete MCA occlusion, early midline shift of more than 5 millimeters in the first 48 hours, and an infarct volume of more than 145 ml in the first 14 hours. So in the first 14 hours itself, if we can do an MRI and we can show that this patient has a very large infarct volume, this patient will have a very high chance of getting worse. So in that patient, if that patient is sleepy and not awake and alert, we would take the patient to surgery early, before 48 hours, and not wait for them to get worse to the point where they start, having herniation, pupillary dilatation, extensor posturing, so on and so forth. Does that answer your question?
Yes, I think to the large extent, because you had shown one slide in one of your patients who did not want surgery with a quite significant midline shift.
Yeah.
And
again,
he improved.
this is right, and that's, this happens. And even on the other hand, even among those who have hemicraniectomy, you still have a 20% mortality. So surgery doesn't save everybody, and medical treatment doesn't kill everybody. So there's always that gray zone, and that's where, sometimes we have to use our clinical judgment and experience. And even then, in some cases, we're not perfect, and we make mistakes.
Thank you. Thank you.
Thank you very much, Dr. Venkatesh, for excellent interactive session. Now we conclude this session. Thank you.